In this presentation, a fracture of the sacrum will be reduced and stabilized with two 7.3 mm cannulated screws. Sacral fractures are usually stabilized with iliosacral screws. This technique is mechanically sound for most of these injuries. The screws must be inserted into the sacrum through a precise osseous corridor, or damage to the nerve roots can occur. Only rarely are the iliac vessels at risk. The presentation will show fracture classification, sacral morphology, patient position and the surgical approach, the implants and instruments needed, and reduction and stabilization techniques. Denise fracture classification of the sacrum is based on 3 zones. Zone 1 injuries are entirely lateral to the neuroforamina. Zone 2 injuries involve the neuroforamina but not the spinal canal. Zone 3 injuries extend into the spinal canal with primary or associated fracture lines. The morphology of the sacrum may vary. Most people have a sacrum with 5 fused vertebrae, but around 5% have 6 fused vertebrae. In these cases, the L5 vertebra is fused with the S1 vertebra. This 6th vertebra has a reduced antero-posterior diameter and a very steep alar slope. The sacroiliac joint has a reduced antero-posterior surface and a different slope. The safe osseous corridor for screw insertion is narrower in the sacrum with 6 fused vertebrae. Using CT images in the transverse and axial plane of a sacrum with 5 fused vertebrae, the safe osseous corridor for screw insertion can be identified in the first sacral body. CT images of a sacrum with 6 fused vertebrae show that the safe corridor is in the second sacral body. It is difficult to insert a screw into the cranial part of the sacrum because of the steep slope of the alar and because the antero-posterior diameter of the sacrum in this area is too narrow. The patient is placed either in the supine or a prone position. For this demonstration, the prone position is used. In the prone position, bolsters are used longitudinally to support the chest wall and pelvis. The bolsters should allow the chest wall and the abdomen to expand without touching the table. For intraoperative control, there are 4 views that may be needed. The inlet view is used to check the sacral concavity, the antero-posterior diameter of the sacrum, and the sacral canal. The outlet view allows the surgeons to recognize the left and the right sacral foramina and the contour of the alar. The AP view enables the surgeon to evaluate the reduction of the sacral fracture and the sacroiliac joint. In the lateral view, the alar contour of the S1 body can be identified. This projection is used to determine the entry point of the K-wire. It is essential that all the relevant anatomical landmarks be clearly seen. However, the presence of bowel gas may obscure your view. Great care must be taken to exclude the contaminated anal region from the operative field. The skin incision is longitudinally oriented 1 to 2 cm lateral to the posterior superior iliac spine and runs 10 to 15 cm in a straight line. The origin of the gluteus maximus muscle is detached from the posterior iliac crest. The sacral attachment of the gluteus maximus is also dissected from the erector spinalis plane. The multifidus muscle is mobilized and retracted medially if necessary to expose the iliac wing and the posterior surface of the sacrum. Care has to be taken not to injure the superior gluteal vessels and nerve that come out of the greater sciatic notch. A finger introduced through the greater sciatic notch is used to palpate the anterior aspect of the sacrum, the fracture line and the sacroiliac joint. The 7.3 cannulated screws are available in stainless steel or titanium and are used with the 2.8mm guide wire with threaded tip. A washer can help prevent the screw head from sinking into the bone. To insert the guide wire, the universal chuck with T-handle and the quick coupling for K-wires are used. Also needed are the direct measuring device for guide wires, the 5.0mm cannulated drill bit used with either the chuck and key or the quick coupling for DHS/DCS reamers, and the large cannulated screwdriver with sleeve. The reduction instruments needed for this exercise are 2 large pointed reduction forceps, the large adjustable pelvic reduction forceps that are screwed onto the bone, and the ball spike. The pelvis is held in place by a clamp applied to the intact iliac wing. Transforaminal sacral fractures are easily reduced when treated in the first days after the trauma. The first pointed reduction forceps is positioned across the fracture site. The sacrum is reduced using the forceps. Gentle manual traction on the affected limb may be required. Image intensification must be used. The second pointed reduction forceps is then applied to reduce any fracture gap in the transverse plane. The surgeon inserts his finger through the greater sciatic notch to check the reduction. The reduction can also be done with the large adjustable pelvic reduction forceps. The forceps are fixed by screws to the posterior iliac spine on either side of the sacrum. The reduction is performed by pivoting the forceps. The reduction is secured by tightening the speed lock. In the case of an incorrect reduction, the usual anatomic landmarks are not valid and the safe osseous corridor is no longer uniform. Before the guide wire is inserted, the surgeon palpates the anterior and posterior surfaces of the ilium to help direct the guide wire. The 2.8mm guide wire is placed on the posterior surface of the ilium using the universal chuck with T-handle. The approximate position is the middle third of a line, 15mm anterior to the crista glutea. However, the exact position is determined with the image intensifier. The wire is then gently screwed in to hold its tip in place. If the initial starting point is incorrect, a second guide wire is placed with the first guide wire still in place. The universal chuck is replaced with the quick coupling for K-wires and the guide wire is inserted across the fracture site under constant image intensifier control. The guide wire should not enter the sacral foramina. When the guide wire is correctly placed, the quick coupling for K-wires is removed. The direct measuring device is slid over the guide wire. The length of the screw needed is read off the scale, in this case 105mm. The 5.0mm cannulated drill bit is now slid over the guide wire and the bone is pre-drilled for the screw. The depth is controlled using the image intensifier. A 105mm long, 7.3mm cannulated screw is slid over the guide wire with the cannulated screwdriver and fully inserted. To provide additional fixation and provide rotational stability, a second screw is inserted when feasible based on the pre-operative planning and the size of the safe corridor. A second guide wire is positioned 5mm posterior to the first and parallel to it in all planes. The position of the guide wire is controlled using image intensification. The second screw is now inserted in the same way as the first. The guide wires and pointed reduction forceps are removed. The path of the two screws in the safe osseous corridor are shown as well as their relationship to the S1 nerve root represented here by the green pointer. The preoperative outlet X-ray shows a sacral transforaminal fracture with a complete sacralization of the L5 body. The post-operative X-rays show the position of the implants in the S2 body. This presentation has shown fracture classification, sacral morphology, patient position and the surgical approach, the implants and instruments needed, and reduction and stabilization techniques. It is essential that the morphology of the sacrum is taken into account. Where there is sacralization between L5 and S1, the screws should be placed in the second sacral body.